Our next speaker talks about another part of medicine, Mika Sinanan, and what he's going to focus on is how do we go about reducing the frequency of errors. Mika, a good friend of mine, went to medical school at Johns Hopkins, and then he went and did his surgery training here at the University of Washington. He got a Ph.D. in GI physiology from the University of British Columbia, and back in, I guess it was around 1990, Dr. Sinanan thought doing surgery by actually opening a patient up was really more invasive than it needed to be. And he was one of the pioneers in actually training to do these surgery through scopes so you could get patients out of the hospital faster. Now at about that time, I was an intern on surgery, and I was one of the people who was using these scopes. And I got seasick because everything kind of moves. And so what Dr. Mika Sinanan and other pioneers recognized is you don't want seasick physicians trying to do your surgeries. So what he did is he was one of the first people to come up with policies and procedures to do this safely. And then where he moved his career next was actually to focus on how do we train the physicians of tomorrow in the most safe way, both making it so that as they learn, the patients aren't subject to risk, and then once these procedures are up in place, that the likelihood of a good outcome is maximized. So with that, I introduce Dr. Sinanan, who's going to talk about Do No Harm, Advancing Safety in Care and Training. Okay.
As Dr. Beauchamp just alluded to, this is a very common experience. In fact, recently at one of our medical staff meetings, I asked a question, and I'd like to ask the group here the same question. How many people have had a family member either injured or killed in military action? Can you raise your hand? So there are a handful of people. How many have been either themselves a victim or had a close family member a victim of violent crime? Can you raise your hand? Third question, how many have either been a patient or had a close family member who has been exposed to a medical error, a serious medical error? So that's about twice the number of either of the two other questions. And it's the common nature of this that we have personally experienced that makes it such a deeply felt issue for all of us. In fact, as a surgeon, I remember every error. I remember every error very deeply and think about it and teach on the basis of it for future generations and do everything I can to avoid it. Today, I'd like to show you some of the technological innovations that we've adopted. We hear about in the popular literature the concept of surgical precision, and yet surgical procedures and interventions are one of the most common sites of error because of the nature of the close contact. In fact, if you think about it, there are really four types of sanctioned assault: war, police action, contact sports, and surgery. And of those four, only surgery has as a goal to make the patient better. So maybe that's one of the reasons that we have such a time struggling with this concept of preserving the patient's health through this. Why do errors occur? We've covered some of this before, but I want to emphasize that we deal with a very incredibly technologically complex field. And there are issues of communication like the handwriting, but also handoffs in verbal communication, communication in the operating room, and sometimes even tacit understandings about how procedures will be carried out. We have systems which have grown organically and have not really been designed to minimize error. They're currently being changed, but this is a ship that has a huge inertia and a small rudder, and it turns very slowly. It's also a very expensive ship, as you know. And we custom craft solutions, unique care for unique patients. So we're not building 100,000 cars like Toyota. So we can't optimize a process for every car. Every patient is unique, and every patient has a unique experience and a unique management plan. Our systems, therefore, are proportionately more complex. From a training standpoint, and we have a very critical role at the institution, at the University of Washington, and all academic medical centers in training the next generation, we have this important role in providing for training, yet at the same time working within a constrained environment. Those constraints, as you can see, are work hour limitations. Our residents can't spend more than 80 hours a week with us. Historically, 90 to 120 hours a week. It's now down to 80. Public awareness and concern for being a patient at a teaching institution, like the guinea pig you see in the Time magazine article. And fewer independent opportunities for the students, the residents, to actually practice their craft outside of the operating room. So what are our goals in this technological revolution around training to minimize error? First, our medical education should not increase the risk for the patient. It may make it less efficient, but it shouldn't increase risk. And secondly, that our trainees should systematically incorporate error awareness and the avoidance of error in their training and practice. We have some best practices to look to. The military, biggest user of simulation. Military budget last year for simulation was $1.4 billion with a B dollars. Medical simulation is in the tens of millions at most in the current era. Nuclear power industry, commercial aviation, where we've particularly identified the issue of the captain as the prima donna, the person who has the first and last say about whether the plane is flying in the right direction or the right altitude, and other crew members stood around and watched the plane fly into the ground because they would not go against the hierarchical system. That era is gone, and now we've introduced crew resource management where every member of the team has value and has a say. And that's very important in procedural, especially operating room type management. But it's not just in surgery, it's also in endoscopy, which is another type of intervention. It's in percutaneous, that is through the skin, or transvascular through the blood vessel system, as in interventional radiology and interventional cardiology. These are all procedurally related areas where error has a technological focus and can be trained with technology. Our new institute, the Institute for Surgical and Interventional Simulation, so-called ISIS, is our spearhead in introducing this kind of training. When we were trying to cast around for a name, we came up with ISIS, and it had this particular resonance I wanted to tell you about, where Isis was venerated in ancient Egypt as one of the most powerful of goddesses, daughter of Ra, the sun god, wife of Osiris, mother of Horus, the goddess of creation, magic, and medicine. Now, this should be horrifying to every one of you who's a patient, but again, every physician is a potential patient, and our families are potential patients, if not actual patients. So this see one, do one, teach one paradigm of training, and it wasn't one, it was see a couple, do parts of, do more of, and eventually take over the procedure, was the old standard. We see procedural simulation as being somewhere interposed between the observation piece and the actual doing piece, to, as indicated, decrease the learning time needed in the operating room, because operating room time at between $15 and $25 a minute is the most expensive time you can imagine, and to provide safe and efficient environment to learn, as well as protecting patient safety. We've also, in building this ISIS system for technological training, incorporated the concept of adult learning. Now, those of you who have grade school kids or have had their children go through grade school or been through, as most of you, all of you have been through grade school yourself, you remember that you were told you will learn this, and we're not going to necessarily tell you why. It's because we say you have to, because it's on the test. Adult learners don't respond to that at all. They respond to a completely different set of motivations, and they have to have their information presented in a different way. So we're orienting our information in this different way. For example, they need to know why, what, how, what's the context, what's the application, why is it important that I learn this, and why is it important that I learn it now. They have a self-concept as a learner, and they're very self-directed, so often if you give them the tools and the direction, they'll learn it on their own. They have prior experience. Our trainees are adults, and they have a huge amount of training. In fact, those of us on the faculty say if any of us were trying to get onto the medical school nowadays, we'd never make it, because those people who are coming in are far smarter than we are. They have a readiness to learn that's life-related and it's needs-based, so they're looking for an application that they can immediately apply. They're oriented to learn. They look for problems and tasks that are very focused on a particular issue, and they can be used to resolve a problem or to gain a solution. And finally, they have a personal payoff. So they're not simply doing this because their family or outside expectations are driving them. They have a personal motivation. So we've incorporated those systems, concepts of adult learning and the best practices from industry, and are trying to train our residents in systems of practice. We are training them in teams so that they work in teams with nurses and medical students and faculty. We give them an opportunity for trial and error so that they can practice over and over again. And if you look at the difference between competency and expertise, the difference really is practice. Expert sports, musical instrument playing, any expert, a true expert, the difference between an expert and a competent practitioner is practice, by and large. We measure and calibrate to allow rehearsal and performance before showtime. Now, the technology that I would like to showcase for you today is based on the concept of simulation. And I wanted to define that for you. Simulation training is training in an interactive, simulated environment that is as similar to the real or actual patient environment as possible and as necessary. And sometimes it's not very necessary that it be very similar, with the opportunity for repetition and for varying the scenario so that you can introduce some variation, because no two patients are exactly the same. No two experiences or operations are exactly the same. For example, I have two videos here, and I'm going to ask you to tell me which one is the expert and which one is the novice. This is expert on the right, got the knot tied. The other one is fumbling around. Now, that's obvious to you and it's obvious to me, but that is a very hard thing to actually measure and to make into an objective description. Is it the amount of time? Well, it's not only the amount of time. Is it the path trajectory? Is it the number of efforts? Is it the frustration level of the person watching this and trying to measure it? There are lots of elements, but trying to actually measure that is very difficult. Our old style of training in the minimally invasive era that Dr. Beauchamp told you about was using suture trainers similar to these. And as you can see up there, these are rubber latex models for suturing, practicing suturing in a box trainer like this, a pelvic trainer that allows you to use a camera and to actually practice the maneuvers. However, we all learned on that, and we recognized that there were limitations to that, limitations in what constituted expertise or competency, and actually what the elements of that suture maneuver, the different maneuvers that went into surgery were. One of our goals in our research studies was to try and capture that information and To do this, we developed a device called the Blue Dragon. Now, the Blue Dragon is over on the far side, and I'll show it to you in just a second. But this is a schematic. It's a 4-bar passive robot system that does two things. It allows you to measure the forces, both directional forces and rotational forces, that are applied to the tissue or the simulated tissue. And it also allows you to measure exactly how far the instrument is moving. So there are, at different points, both movement sensors and pressure or force sensors. And by that, instead of saying an operation went well, or this one was the novice and this one was the expert, we can say at a 30th of a second frames, every 30th of a second, this is exactly what happened. This is the force that was applied, and this is the amount of movement that occurred. Putting that together, we can analyze an expert and a novice and describe their performance as a pattern of performance, of efficiency, of force, and of rotational force and of movement that very accurately describes their movements. I'd like to ask my colleague here, Jed Kaufman, who's one of our fellows in video endoscopic surgery, and I'm asking Jed to do this because I figured if I held the instruments and fumbled, none of you would ever come to see me as a surgeon. So Jed's kindly going to be a demonstration here. And I have my colleagues from the biorobotics labs who are the smartest people I know, Jacob Rosen and Mitch Lum, biorobotics lab on the upper campus here at the university, who have developed this device. These are one left hand and right hand Blue Dragon devices. You can see from the blue color and the shape why they're called Blue Dragon. And here we're dissecting a gallbladder model that is anatomically correct, and it's been modified so that the forces that are applied mimic the forces that are applied in surgery to get the same amount of dissection done. And so we can, with this device, actually do an operation. And we do operations on simulated organs, and we do experimental surgery this way. This device hasn't been taken to the operating room for obvious reasons. It's very difficult to get it sterilized, and there are human subjects issues around that. But we have done whole procedures with this device and collected that information by experts, by novices, and by resident surgeons, trainee surgeons at different levels. And what we can capture from that, if we go to the data screen, is not only the actual maneuvers that are being done, captured on videotape, but also the forces and movements as vector diagrams. And so we capture that information on videotape, and it's every 30th of a second. We can play that back and know exactly what the surgeon was doing at each frame of the videotape, very precisely. And then play this whole thing back, so play back an entire operation. Or plug it into a surgical robot and have the robot do exactly the same operation. So here, we're dissecting the base of the gallbladder and coming around close to the cystic duct, which is the connection between the gallbladder and the main bile duct that goes up into the liver. And you can see the kinds of forces that are being moved around. Thank you. Now, taking that kind of information, we can put that information together in aggregate and actually map out the course of an operation. And an operation is not only first we divided this, and then we divided that, and then we clipped this, and then we suture that. That's one way of describing an operation. But here we've described the operation in terms of the magnitude and the duration of the procedure and mapped out 3 different lines. In the green, you can see the force that's been applied over time. And there are times when this expert doing this operation applies a lot of force, and other times when the force is minimal. We can look at the instrument velocity, which is the speed that the instrument is moving. Sometimes it moves very fast, and sometimes it moves very slow. That's in blue. And for the purposes of this lecture, also define the relative risk of error. Because there are times in an operation when you're close to vital structures, close to big blood vessels, in an area of uncertainty, and what happens? What does the expert do? The expert slows down. So how does this vary between an expert and a novice? A novice doesn't slow down, doesn't speed up, maintains kind of an even pace throughout the operation, and often flails a lot. The expert applies high force, high speed at certain points and slows down. So a way of categorizing the risk of an operation is by mapping this out and mapping out the times when the surgeon moves slowly and the times when the forces are least. Those are the times when the error, the potential for error or risk is highest. And we can take this information and train the next generation of surgeons to be very careful during this part of the operation, that part of the operation, because our experts objectively have said over and over again that those are the riskiest parts of the procedure. Now, taking that kind of information, we are in the process of developing a new generation of simulators. We have some that we work with now and some that are going to be coming online with information like the Blue Dragon has provided us. The first simulator I'd like to show you is this virtual reality simulator. And this is a simulator that has two instruments. You can see the ends of the instruments don't have any actual effector piece, but Jed can look on the computer screen and see what you're seeing. He sees instrument ends. He sees a needle and suture. He sees the stomach surface. He sees a target that tells him where to put a suture. And he can pass that suture. And though not 100% accurate, the quality of the tissue is pretty close to normal. What he doesn't have in this simulator is any force feedback, because you can see the ends of his instruments are just in the air. There is no force being applied. So he has to imagine that force. But he's got a lot of visual cues as he tries to learn how one of the most difficult maneuvers in laparoscopic surgery, which is tying a knot. This modeling of suture material also happens to be one of the most complex simulation tasks as well. And so here he's been able to throw the first knot, and the little cue at the bottom says, "Good job, tie the second knot." Now, this kind of a simulator measures the trajectory of the movement. It doesn't measure force. It measures the number of errors. It measures the time that his instruments move out of the field, and it measures the times he drops the suture. So it gives us a lot of objective measures that are analogs for error and can help training, but they're not exactly the same errors and the same risks that we've identified through the Blue Dragon. So this is an interim step in our technology.
Want me to keep going?
Did you get a second knot? I don't know. It says tie the second knot. You haven't done it yet.
I'm going to have to apologize to the patient in a second. I'll be very forthcoming.
Well, it's really quite hard. We set it to one of the harder levels, so you'll have a chance to try it in a few minutes too. Yeah, especially when you have an audience. Okay, so we'll go to the next slide. Simulators like that allow us to train not only suturing and knot tying, which is on the far lower right, but also camera navigation, moving the laparoscopic camera, like this laparoscopic camera around, and finding the target when you want to. They allow us to practice grasping and cutting using electrocautery. And they also allow us to simulate error when you tear a blood vessel and you get bleeding. We also have a number of physical simulators, and those simulators are highlighted on this table close to me. They are simulators that a company that we've worked with in Seattle, Simulab, worked with for a long time, has developed with help and advice and input from us about things that we think would be valuable in the training of surgeons and others who are doing interventional techniques. This first simulator here is a physical simulator, and just as Jed was suturing with a virtual reality simulator, you can see here that he will be practicing suturing and knot tying with this little bit lower tech, video camera, laptop computer, trainer box simulator. But this one has force feedback because it actually has a physical structure at the other end. And he's using actual laparoscopic instruments, which allow him to practice with the actual tools. And he can practice over and over again to perfect his suturing and knot tying capability under a situation or under conditions which will improve his safety and his efficiency in the operating room. So you can see we've magnetized the instruments there. And again, I would encourage those of you who have a few minutes to stay afterwards to come up here and try this. This is, as I said, one of the most complex integrative tasks. And one of the things about this task, and video endoscopic surgery by and large, is that it's a three-dimensional movement in a two-dimensional field. So you're seeing everything on a video screen as a two-dimensional structure, and you're having to move in a three-dimensional field. And that, when you're trying to reach forward and back, grasping the suture and moving the instruments around, is a very challenging task. There you go. Thanks. We have two other simulators here, which are physical simulators for open surgery or open surgical or procedural type of things. The first one on the far end of the table is called Trauma Man, and it's used for the training of paramedics, surgeons, emergency medicine doctors, and others who are learning the initial management of traumatized patients, major car accidents, gunshot wounds, and the like. And it allows one to drain fluid and air out from the chest cavity, to do a tracheostomy if a patient's face has been injured and an airway is not possible, or to drain fluid from around the heart. In fact, pericardiocentesis for a patient who's had a chest injury and has fluid pressing their heart is one of the emergency maneuvers that we can practice. Go ahead. And there he's pulling the fluid out from around the heart, the blood which was pressing on the heart and keeping it from fully expanding, and thereby compromising the patient's blood pressure. We also have another simulator here for central lines. Those of you who have had IVs in the past know that sometimes for some drugs or patients who have no veins, an intravenous line needs to be inserted underneath the clavicle or into the neck to give certain drugs, or if there's no peripheral line. And so this is a device which allows one to practice that technique and to minimize the risk of hitting the artery, which is right beside the vein, or hitting the lung, which is right underneath it. We also have an ultrasound machine. I don't have it set up, but we can look at those blood vessels with the ultrasound device and help with the guidance of the needle in, again, for training purposes. So these are physical external simulators for other applications and other types of procedures. Who do we use these simulators for? At all ranges of the technology, the most high-tech, virtual reality, the medium tech, the physical simulators. We use them for all members of the healthcare profession, physicians in training, physicians in practice, medical, nursing, and allied healthcare trainees and students. We have not yet, but we hope to be able to use it for patients and their families to actually demonstrate for them visibly, not just in a videotape or by diagrams or pictures, what a procedure involves. And ultimately for you, the passionately interested public. So our ISIS Institute for Surgical and Interventional Simulation is really dedicated to patient safety. And the important aspects about that I wanted you to leave with today are the fact that this is a very, very high-level institutional commitment, not just at the University of Washington, but in medicine and among all of the interventional specialties. That we have emphasized team training. that we are trying to create the capability for practice, for repetition, for actually creating errors and then recovering from them, and for recognizing the potential for error or the actual error and correcting it. We want to measure performance so that those practitioners who go out there to practice, who leave our medical school to practice surgery or other types of interventional related specialties, are as expert as possible and certainly competent. We want to embed this in a formal curriculum because active learners, adult learners, learn when they understand the context and the application. And we want this to be oriented for the adult students so that they can rehearse for their clinical practice and future career. Thank you very much.
So we talked about, when we first started, the innovation cycle, which I think is what characterizes an academic institution like the University of Washington. A clinical problem, creating a new approach to it. So at first, a general surgical approach that was open surgery, but then a delay in recovery, leading to a new approach that was developed with the research and then translated down to new teaching and then clinical application with, again, new approaches and new problems identified. And it's this innovation cycle that really characterizes what's occurring. And what makes academic medicine particularly interesting is that those discoveries translate to better care for our patients today. And that's what we wanted to try to give you a sense for.
Hey, how's it going? Hello, Simon. Oh, you're so great. Hi. How are you? Hey, he's waking up. Hey, how you doing? Thanks for letting me take part in this.
A curriculum review at the University of Washington School of Medicine identified the need for more focus on core clinical skills, professionalism, and personalized education. Throughout their education, students take part in a unique program called the Colleges. Within 5 colleges staffed by 30 faculty, small groups of second-year students spend half a day each week at the bedside, working with patients and a faculty mentor. This mentor guides the student for the duration of their education.
One of the ideas that rose to the surface was the idea of linking a mentoring program with a curricular component. And in a way, that's how the colleges sort of came into being.
So the colleges are a way of assigning students right from day one in medical school to a college mentor who will know that student, develop a relationship with that student, and work with that student, particularly in issues of clinical skills, throughout their 4 or 5 year journey in medical school.
To be at the bedside early in our medical school career, particularly in the second year in the college system, really allowed us to have early exposure to what it's like to be around patients in the hospital, and probably more importantly, how to gather information effectively on a patient that's hospitalized.
The college system was great for that. It gave us one person we could always expect to see weekly, someone who could watch our development and could kind of direct us.
Blood pressure was 116/65 and his respirations were 12 to 13 in regular.
Talking to patients, giving feedback about how that was going, and having that early on is going to build habits that they continue with through the rest of their life.
Take care of yourself.
Okay, you too.
All right.
It's nice to meet you all.
Yes, thank you.
Yeah, good luck in your careers.
Thank you.
One of the important outcomes of our college system will be that our graduates will be more comfortable and skillful in relating to and caring for their patients. In general, I believe that our college system will produce physicians with more skilled professionalism in their approach to their patients.
Ms. Burke is a 44-year-old female who came in.
I think it's really important to learn how to present a patient with dignity and to learn how to present a patient with enough respect that you would feel completely comfortable to have that patient in the room with you when you were presenting them.
We talked about professionalism. We talked about one of the things I think we're going to talk about today. The college faculty group as a whole has become a very rich learning community itself. It's an incredibly inquisitive, dedicated, highly professional group, very value-driven. Clearly puts patients at the center of the training of medical students and clearly puts medical students at the center of medical education.
Dr. M.H.S. as my mentor, she knows our strengths and weaknesses, and I think she also knows our motivations.
I think developing how to do that differential is that will develop throughout your entire career. I mean, I still work at it, you know?
It's valuable. I think it's very valuable to know that Dr. M.H.S. as a mentor is there to just talk with and debrief with, if nothing else.
It's amazing how a small group of 5, 6 people in your college group, how they can provide totally different aspects or reflections on a certain situation, and how you can learn from such a small group of people, and in a very non-threatening way, in the presence of one faculty member.
You may insert parts of the history into the physical or parts of the physical. I heard a little bit from both presentations today, and we're just starting, and we'll make you more aware of it as we go on.
I think they get a more comprehensive and more consistent educational program in terms of their tools for clinical medicine. How to do a complete history, how to do a complete physical exam, what is the clinical reasoning involved, and how to do a very good oral case presentation.
And it's pretty hard to practice patient-centered care unless you can remember that the patient sits at the center of the experience. When you go to the bedside, that's exactly where they are.
It was interesting hearing that doctor and them talk about all the different aspects of my disease that nobody talks about. So it was a learning experience from that point of view, yeah.
And a lot of patients have a lot of experience being patients, and so they've sort of seen it all in terms of physicians, and they can pinpoint what's of value to them and almost of universal value to all patients.
That immediacy, that urgency of learning is one of the most motivating things in the world. It's one of the most exciting things in the world.
You know, part of what happens when you take histories is you get a little piece from here and you get a little piece from here, and it all comes together, and it will happen so often to you during your career is that you're telling somebody about a patient and you walk into the room, you start talking to the patient says something totally different. Doesn't mean that you were wrong, it just means that remembrance is something, it's a dynamic process.
So there is no redness, there isn't, what else is there? It's not tenderness.
There is nothing more powerful than say, no, let me show you how to do it this way. Reading a book doesn't get that to you.
But you might feel the thrill, put your stethoscope there. Brewery might also sound similar, never as this loud.
If you guys want to put your stethoscope on, just don't be bashful, just go ahead and do what you got to do.
One of the greatest things is the look in their eye when they first hear the murmur. It's just like a light bulb went off.
Can you hear it?
Yeah, it's quite striking. Yeah.
And at the end of the year, typically we've got them ready to walk out onto the wards, into a clerkship, and not be that deer in the headlights, but to be ready to go, ready to work, ready to really pitch in and run with it.
To make the kind of commitment that the dean made to fund 30 core faculty to spend as much time and energy and effort revising a curriculum and trying to teach it at the bedside is certainly unique to this institution to the degree that we're trying to do it.
It's been rejuvenating for the faculty. It's rejuvenating for me as dean to see the faculty so engaged in teaching what is basic to medicine.
I think that's great. I will always remember the skills that they helped me to develop and the role they played in my schooling. And I love them all, and for their uniqueness and their sincerity and their commitment to medicine and their knowledge, probably more so their knowledge. And so I will always sort of remember that, and it makes me happy.
It cements in the student what they came in with: dedication to patient care, dedication to service, and that real compelling desire to be the best they can be.